An epidemic causes chaos everywhere. People are frightened, not knowing what or who to place their trust in. Governments and healthcare workers often don't see eye to eye. Community leaders may have different points of view, and the internet is rife with conspiracy theories. All this creates a confusing environment filled with suspicion and doubt.
The level of distrust that we see now all over the world expressed towards governance is so high, and the confusion people have in their minds about where is this thing I call health, where is this thing I call government, where is this thing I call industry and profit making, where is this thing I call the internet and reliability of information. This is just a huge blurred mess now.
The 2018 Ebola outbreak in North Kivu in the Democratic Republic of the Congo was a particularly challenging one. Rebel groups caused unrest, and healthcare workers found it increasingly difficult to administer the vaccine. The World Health Organization and MONUSCO were called in for emergency relief and security support. Again, trust within the community was a huge issue.
When it comes to Ebola, indeed, there's a lot of suspicion about Ebola here. Some people initially thought it was some sort of a joke or some sort of a government plot to postpone the elections. That made things actually really difficult for the WHO Ebola relief workers and their colleagues from other UN agencies and NGOs.
Dr. Jean-Jacques Muyembe, who has led the Ebola response team in the DRC, took the vaccine himself in 2019 to build trust.
I am exposed to the disease. It is why I came here to receive this vaccine.
And now with COVID-19, the same issues of trust are erupting all over the world.
Aujourd'hui, la COVID-19 arrive dans une communauté, dans une province qui a vécu Ebola. Et certaines des mesures pour lutter contre Ebola s'appliquent aussi pour la COVID-19. Mais cette résistance demeure à un certain degré parce que quand la pandémie a été déclarée, la population était en train de suivre ce qui s'est passé en Europe. Elle a vu beaucoup de gens mourir en Italie, en France. Et alors qu'ici chez nous, le pays n'a pas enregistré beaucoup de morts déjà, et aussi la province n'a pas enregistré beaucoup de morts, même s'il y en a. Cela aussi a eu pour effet de faire que la population ne puisse pas croire que la maladie était réelle.
In all these cases, taking a nuanced approach is important. A standard playbook has to be disregarded for a community-specific approach, engaging leaders and locals.
I think the more you can build trust locally, the more resilient it is to higher level distrust.
Au niveau de nos communautés, l'État congolais, avec ses partenaires, a mis en place un système de sensibilisation à travers de sensibilisation porte à porte, à travers des causeries éducatives ou des réunions d'information pour que la communauté soit informée sur les dangers de la pandémie. Je pense que l'État était devant, elle a accompagné les structures et le médecin à leur tour, ils ont fait un effort pour chaque fois discuter avec leurs patients, les rassurer. C'est vrai, on peut avoir une toux, avoir la toux n'est pas nécessairement égal à la COVID-19.
Epidemics can pose a real challenge to healthcare workers. It is vital to engage with the various communities where healthcare workers operate. Engaging with community leaders and representatives can vastly improve trust between healthcare workers and the population at large.
When an epidemic occurs, there is the clinical management, but there's also the reactions of society. And managing that can be as important as actually dealing with the epidemic itself.
We need to engage the patients and the public. They need to message correctly, and they need to message in a contextually correct way. In some cultures, one-on-one sort of didactic learning or teaching, awareness raising is not how awareness is raised. I mean, the most basic example, in a village in Africa, you may find, that the oral tradition and the imparting of information that will raise awareness and change is not done by the doctor or a healthcare profession, it's done by a leader.
Engaging with the community is an ongoing process. It doesn't just begin when there is an outbreak. Continuing to engage with the community and community leaders builds trust and educates the community on prevention methods so that when an outbreak does occur, people know what to do to fortify themselves. Early community intervention can really curb the spread of an epidemic.
Not spread the disease or get themselves sick.
One of the problems during the 2014 Ebola outbreak in West Africa was that there was no experience with the disease.
Le grand problème, c'était en Afrique de l'Ouest, ils n'étaient pas préparés, ils ne connaissaient pas la maladie. Il faut rapidement un engagement de la communauté. C'est une maladie socio-culturelle. Il faut dès le départ que la population comprenne qu'est-ce qu'Ebola, comment Ebola se transmet, comment éviter la transmission d'Ebola pendant les enterrements traditionnels. Ça, c'est très important.
During the 2018 outbreak in North Kivu, community engagement was very hard because of the conflict in the area, and containing the spread was a challenge.
Pour nous, c'est l'épidémie la plus difficile à cause des problèmes d'insécurité, plus difficile à cause de non-engagement des communautés. La population montre une grande résistance et qui dure jusqu'à présent. Et également, la population se déplace beaucoup.
Currently, the COVID-19 outbreak demands intense community engagement by healthcare workers.
Communities know their local healthcare workers, so they, as a trusted agent, as it were, can have a very important role in both listening to public concerns as well as making the government recommendations have a more personal meaning.
In the North Kivu region of the DRC, healthcare workers are working hard to spread the message about COVID-19 amongst the communities.
Les communautés connaissent qu'est-ce qu'on appelle mesures barrières. Elles connaissent ce qu'il faut faire pour se protéger grâce aux sensibilisations porte-à-porte, notamment, grâce aux communiqués sur les radios, sur la télévision, grâce aux émissions, grâce aux magazines, mais aussi grâce à la communication de bouche à oreille. La communauté a été informée comme ça.
Many thanks for joining us for this panel discussion today on building trust around clinical trials and vaccination deployment and engaging the community. I'm sure many of you have come straight to this session, not just because it's panel one, because it's the most interesting panel. And we look forward to a very good discussion here this afternoon. Building trust effectively engaging the community is an essential component for any community development activity, but it's particularly so important when it comes to carrying out a clinical trial for a vaccine for a disease which is already shrouded in mistrust and misinformation. The EBODAC project has been developing strategies and tools to promote the acceptance and uptake of new Ebola vaccines to ensure that the right person receives the right vaccine at the right time since 2014. And we've been engaging community members to build trust for this essential work since then. Over the period, we've developed and implemented a community engagement strategy to build awareness and trust for Ebola vaccines. The work started initially in Sierra Leone, but has expanded to cover support to clinical trials and mass vaccination campaigns in the Democratic Republic of Congo, Rwanda, and Uganda since then. And we're delighted today to bring you our combined learning and experience from across these contexts to provide an exciting discussion on building trust and community engagement. And at this point, I'm very happy to introduce our panel. First of all, who is Mr. Tom Mooney, our Senior Communications and Advocacy Manager with CEPI, and Tom previously worked with the EBODAC project in Sierra Leone and supported Uganda as well. We have Marie-Michelle Umusila, who's the Executive Director for Mrinda Ubuzima in Rwanda, supporting the mass vaccination campaign in Rwanda. We have, who just joined us, Dr. Bob Dejuma, who's the EBODAC Project Manager for World Vision DRC and has been supporting the project in Goma since its inception last October. We have Angus Even Tembe, who's previously worked with the London School on the social science work for EBODAC and has most recently evaluated the EBOVAC Salone community engagement strategy, so coming from both sides of the work. And we have Claudia Mara, who's a community liaison facilitator with World Vision Sierra Leone, who supported our work there. So we're going to have sort of a first round of introductory questions where I'll pose a question to everyone, and then we might have some follow-up ones and over and back. So Tom, can I just start with you? And maybe you might tell us some of the considerations that EBODAC and EBOVAC had to look at the start of the project, and what were the main points of consideration for community engagement and developing the community engagement strategy?
Sure, thanks Maurice, and apologies for not having my camera on today while I struggle with London internet. I guess it's good to start with me and Sierra Leone as kind of the first project that EBODAC took on in terms of community engagement. And for some context, we set up the EBOVAC Salone clinical trial of the J&J vaccine in northern Sierra Leone towards the tail end of the epidemic. So people had been living with sort of restrictions and the fear of Ebola, but also lots and lots of outsiders in their community working on the Ebola response for well over a year by the time we arrived to set up the trial then. Lots of people were really kind of desperate for the epidemic to end and for a solution to it of some sort, or medical or otherwise. Excuse me, we were also one of the first vaccine trials to take place in Sierra Leone, and certainly the first in Cambia district. So there was quite a limited level of knowledge in the trial community about clinical research before we set up the trial there. I should mention I was part of a team working on this with Claudia, who's on the panel today, which was led by Dr. Beth Smout, originally from London School, and also Mr. Abdul Deen from the College of Medicine in Sierra Leone. And I think I could probably talk about this for hours, but I won't. But I think there are a couple of sort of core enablers for us, and then a few sort of key principles in our approach to community engagement and trust building. So the first enabler, it's more than an enabler because it was absolutely critical, was the work done by our social science team, which I'm sure Angus will talk to. So before we began work on community engagement in Cambia, our social science team did some initial ethnography and power mapping, and that was absolutely crucial for us in terms of our community entry work, how we developed the engagement strategy, and also devising appropriate messaging. And throughout the trial, that social science team also did real-time rumour monitoring, feeding back to both us in community engagement and also the clinical team about concerns, rumours, and providing suggestions about how best to address those. So that I can't stress enough how important for us and how lucky we were to have a social science team supporting the work that we did. And I think the sort of second enabler was relationships. So the entire community engagement team were recruited from Cambia. They were respected members of the community. They developed strong relationships with community leaders and trial participants, and those are also crucial for building trust. I should mention those relationships and the importance of those relationships. It goes beyond the community engagement team when you're working in a clinical trial. In a small community, every member of that trial team was seen as a representative of of the trial. And so both in and outside of work, their informal relationships with their neighbours and their colleagues and whoever else in the community were also very important for trust building. And then just a couple of principles on which we based the community engagement strategy. The first, I think, is transparency. So we endeavoured to be open and honest with community members and participants. Examples included when we arrived, we opened up the clinic for an open day, invited people in to see the facilities, meet staff, see the equipment, the syringes, blood tubes, those pieces of equipment that may have been unfamiliar to people otherwise. When we started up, there was a lot of demand to join the trial because of, well, partly because of the epidemic was still ongoing, and we held a selection process to select houses that we would allow to volunteer as a way of managing demand originally. And actually we did that in public. We went to the Chief's Court and held that in public. People could come and be part of that selection process. So again, as part of the sort of transparency piece, rather than having people think that we were selecting only those who wanted to or who were seen as favoured. And I guess the final piece on transparency was we made a policy of always informing our stakeholders and our participants, community members, around the progress of the trial, and that meant the good stuff as well as the bad stuff. So when we had SAEs in the trial, which we did have a few, and study pause, we were proactive about going and telling people that had happened, so that they weren't hearing information secondhand, or there wasn't opportunity for misinformation to circulate. So I think that was very important in terms of people seeing us as a reliable source of information and people who are honest and trustworthy. I think another principle is reciprocity, and my former colleague Sarah Dada wrote about this when she was looking at the work which we'd been doing. And it really, we tried to make sure that we had a dialogue with community members and participants, and that we weren't just broadcasting information. That's very, very important, I think. We established mechanisms for dialogue, both formal through participant and stakeholder advisory groups, and carrying out feedback surveys at clinic visits to find out how people's experiences had been, but also informal dialogue through the social science teams, ethnographic work, and also personal interactions from the community engagement colleagues. And again, these really helped secure some community buy-in and ownership, I think, of the project, as people felt that we were taking on board their feedback. And the final principle that I wanted to describe is respect, which sounds like a basic one, but I think we tried to demonstrate respect for the community that we were working in by sort of really actively listening to concerns and rumours, not dismissing people's concerns, and trying to take action where we could, either by communicating more clearly or in a different manner, or in some cases actually making practical changes to the way that either our community engagement was run or things in the clinic were taking place, so we could improve the experience for people. It showed that we were, trying to listen as best we could. So in summary, I'd say we devised a strategy, but it was devised by a team of people who were from that community, implemented by those people, and it evolved over time in response to feedback. And I think that's what made, what I hope was an effective way of sort of building and maintaining trust over the course of EBODAC.
Perfect. I think you nearly raised a question at the end, is that you hope, and we have a man who actually will be able to tell us whether the hope was right or not, because Angus has just been involved in evaluation of that community engagement strategy. So Angus, maybe you can give us some headline findings from the evaluation, which, although isn't published yet, you might be able to tell us some of the key issues, and if Tom is actually correct or not.
Yeah, thanks, Morrison. So as Tom rightly said, the evaluation really found some interesting things about the work that they were doing, because the evaluation was established for us to try and to see whether the community engagement itself was really effective in building participant trust and confidence in the trial, in making people understand about the trial, and also the retention rate, whether they had any impact on participant recruitment and retention. So the approach of the evaluation was we use a mixed method approach where we use both the qualitative and the quantitative aspects. We conducted a survey in the community with both the trial participants and non-participants as well. They also had key informant interviews with community stakeholders, and we had in-depth interviews with participants and non-participants because we wanted to have a right balance of information. So we are looking at three things, just like what I mentioned. One, we look at the knowledge and understanding of the trial, whether they were successfully in doing that. They will also look at the trust and confidence building, if they are actually impacted on that. However, on all the three key pointers that we are looking at, there was a huge success. So like for the community understanding and knowledge about the trial, we realized that about 95% of people we interviewed at least have some understanding about what EBODAC was doing in the community. This was basically because the community engagement adapted and used the locally accepted methods to go to this community and talk to them. Things like face-to-face conversations with the trial team. And also they had a lot of one-to-one meetings and community meetings in those communities. So this led to a huge understanding of the trial because you were using the local languages. They never use English, but they were using local languages like Femini and Creole, which people really understood and they appreciate that very well. However, we realized that so the community engagement was successful because they adapted the locally acceptable methods, like using the local languages, Creole and Femini, because in that community, a lot of people are really locals. They hardly speak English. So they really came down to their level, talked to them in their local languages, and they also demonstrated. So all this led to a huge success of people understanding what the trial was, what they were actually doing. However, we realized that there was a low level of people actually understanding what the aims and objectives of the trial were, that they were actually there to test to know whether the vaccine will work or not. However, we realized that about 48% of participants and 55% of non-participants recall what this trial was really doing, that they were actually testing to know if this vaccine will work or not. However, this evaluation was conducted after a long time because at the time we were engaging the community for this evaluation, there were no effective community engagement activities happening anymore. And we had this COVID outbreak, so people were not talking about that. So maybe that could be one of the reasons why we had this low level of recall about the aim of the trial. Notwithstanding that, we realized that a huge number of people, about 95% at least, realized that the trial was there and they were working in the community effectively. Regarding the trust and confidence, we also realized that there was huge amount of trust built because just like what Tom mentioned earlier, the community engagement team used people who are from the locality, people who have been working in the community for a long time. They gave them the priority, they gave them the opportunity to lead on the engagement strategy. So people seeing those that they already knew in those communities, that really had a lot of impact in building trust. Overall, we also had a very prominent leader who people trust in the community. He also was involved at the very beginning of the trial. He himself participated willingly because we had what we call a lottery. He picked his own house by chance and he was willing to participate in the trial. I will talk about that later. So that led to a very huge success in building trust and confidence because people who were telling us that, well, for them, they know that once the paramount chief is part of the trial, they know that the chief will not bring anything dangerous that will kill them. And people were also saying that once they saw people they knew, people that have been in those communities, they trust them and they realize that they will not bring anything bad in their own community because if that happens, they will all face the consequence. Then regarding participant retention and recruitment, overall, there was a very high number of retention. From the clinic data, we realized that about 83% of people we are retaining the study. Then from our own data, we had that about 99% of people said they went to the clinic and they attended all their clinic visits. This was because of various individual motivations, but in particular, people who are keen that they wanted to be part of this history-making trial. They realized that if this particular vaccine succeeds, they were part of the history, that their names will be written and people will see them as heroes. So we have these various individual motivations and perceptions that really made them not to drop out of the study. Like some we are saying that they realized that they were afraid of risk, because they said if they tell them to go for 1 year, if they drop in between, maybe something bad will happen to them. So because of that fear of risk or for the uncertainty, they said, well, they had to do it and complete the trial. So these are just the pointers about the evaluation that we did.
So already we can see a theme of localization and making sure that we include local communities, their involvement in the setup and design and communication of it has been a really important theme that's coming out already. And I'm glad, Angus, you mentioned the Paramount Chief, because I remember my first visit to Cambia, he happened to be at the clinic for one of his visits, and it was pointed out that it was a really important element of the trust of the whole clinical trial was the fact that he was a member of it. So it's a really good point. We're going to jump to Bob and ask Bob, who is supporting the EBODAC is supporting a different clinical trial in DRC based in Goma. And it's a very difficult and different working environment, Bob, that you have to deal with in Goma. Both the fact that in Goma, it's a very urban setting versus very rural Cambia, and some of the other challenges in terms of conflict and trust within that. Can you tell us some of the challenges in sort of community engagement within the clinical trial there and how you've overcome those?
Okay, so the first challenges was, Goma and North Kivu is an insecurity zone, so it was not easy for community to accept Ebola response and all of activities around Ebola response. This community faced insecurity for several years without having NGOs come to support them. And it was first time to them to understand about the vaccine trial. And when the vaccine trial began in Majengo and Kayembe, these two quota, where we found many people from Beni and Butembo, for them it was a strategy for eliminating them as the massacre by the HDF did not succeed. So many strategies was implemented to make them understand the importance of the vaccine trial, such as the recruitment of community members as volunteer health workers for door-to-door sensitization, collection of community feedback through community-based listening point, to understand the community perception, to collect remarks and propose response. Training of community leaders, faith leaders on Channel of Hope Ebola model approach for sensitization in church and community. Also, sensitization, I can say, in schools. So this helped us to recruit more than 2,000 participants for the first dose of the Gen-G Ebola vaccine. Prior to the suspension of the vaccine study, following the pandemic of COVID-19, the return for the second dose was high. But after 6 months of suspension, the return is timid, and we are facing other rumors such as the use of COVID-19 vaccine during this resumption of Ebola vaccine. This is a very big challenge, but we continue to sensitize in community by door-to-door sensitization, by community feedback, by collecting community feedback through listening point. We have also do some advocacy to faith leaders, with faith leaders, to explain the reason of the suspension, and also to explain the importance of taking the second dose because the second dose began before the suspension. I think we do 1 month before the suspension, and also we are telling them the Congolese government didn't allow us to use the COVID-19 vaccine. So these are strategies that we are using to bring more people to participate in the second dose vaccine. In a few words, I can share with you on yes.
Perfect. That's very good to hear. And I suppose it shouldn't be a surprise to us when we're talking about community engagement that the involvement or the use of community members as those delivering the messages is a key strength across both contexts so far. Let's cross over the border now to Marie-Michelle. And even though we're working in Rwanda, very, very close to Goma, it's a very different operating environment once again, Marie-Michelle. And maybe you can share some of the lessons from setting up and supporting the mass vaccination campaign in Rwanda. And so does any of what you're hearing already kind of resonate with you? Does it sound familiar to what we're hearing from Sierra Leone and DRC, and maybe some of your lessons from there?
Thanks a lot, Maurice. Yeah, our lessons from what we are doing as NGO implementing community engagement for Ebola vaccine campaign is that for the community engagement, we had challenges first. Which challenges was first to start in a country that do not have Ebola vaccine, Ebola issue. And second one, it was to, the targeted population, because initially we targeted those areas where people can cross border to RSC regularly, because by that time in Congo, they have an outbreak of Ebola. So people were asking, why for Rwanda? Why for us? Those vaccines should go to Goma, because Goma is the one who has Ebola vaccine. So in the beginning it was not that easy. And also the other issue is that those people were targeted and people who are very busy, business oriented. So for them, their issue was to cross border and work and come back, where the hours for cross-boarding was early very morning and coming back late afternoon. And it was really kind of challenging. And another one was the site where the vaccination site. We do have vaccination site, and we have people who want to come for vaccination in the community, but then they live so far from the community. So following up people also was challenging for second shot. And then Ebola came in. It was also another big challenge, but we tried our best. Even though we have those challenges, we managed to get a very big number of people coming for vaccination, because the period to start the vaccine, we started in December, but by October, we were already in the community doing assessment, what people know about Ebola, about vaccine. We didn't be so easy for people to accept the vaccine. So assessment was done very early stage. So we have chance to respond to the questions, concerns, fear before we started the vaccination. Also, another strategy we used is to involve all stakeholders that we thought would be very useful for the Ebola vaccination campaign, such as community engagement, local leaders, all stakeholders like promoters were really involved well before. So they were helping us in mobilization, sensitizations, but for them to know how they should help us, it's because we also trained them before. So we have been providing some trainings, we have been providing materials, thanks to EBODAC. Before I forget, we have got also training from them before, and also we have been provided some materials, which materials we tried to translate into Rwandan context. Then we use them for all trainings we have been doing. So because they hear people in communities in Rwanda really respect local leaders and also communities workers. That is why they were targeted to be involved in that journey.
Thanks very much, Marie-Michelle. We'll come back to some more of the points in a minute. I'm going to jump to Claudia with a question, and she'll have picked up on something you said, and it'll be familiar to Claudia. Is the fact that you mentioned there that there was no Ebola in Rwanda at the time you started the campaign, and people were saying it's in DRC. And one of the things I spoke to Claudia previously was the fact that in March 2016, thankfully Sierra Leone was declared Ebola free, but the clinical trial continued. So I'd be interested to hear of how the community engagement work had to pivot, or what changes had to be made at that time to engage people and to continue to get them to be part of the clinical trial, given that Ebola was no longer an immediate threat.
So some of the strategy we use at that time when Ebola is finished. So we try to engage stakeholders. We talked with stakeholders, and then as well with community people, engage them with several meetings through the chiefs, the local chiefs. We engage them with several meetings, like Ebola is now finished, but maybe some other time Ebola will come again in our country. So if you have this vaccine and this vaccine works, it might prevent you to have the Ebola sick. So we try to engage them, we explain to them, we sensitize them based on the value of the vaccine if it works. So through the help of community stakeholders and the chiefs, we are able to explain well to them, and the community people accept. We have a great acceptance from them and compliance. And we engage them as well with radio discussion programs, one-on-one discussion, different meetings. Like for our engagement with community people, we do engage them in different sessions. Like in each cohort, we have different targeted people. Like if we are dealing with the adult participants, we know we have to go to this attire base where the adults normally sit. We have to go to the religious leaders. We have to go to the area chiefs to meet with them. So when we go down to stage 2, wherein we are dealing with the adolescents, we have to conduct school sensitization, because here in Sierra Leone, more to be precise, Cambia, these parents have more they believe in their kids because they think they know it all, because they are their future. So they think they know it all, and they are educated even at that level. For them, they think they are educated and they can explain things. So what we did at that point, we tried to get to these schools and engage them, engage the pupils, talked with them, conduct trainings for children. We conduct training with teachers. We conduct trainings for this CWC and this child welfare committee. We conduct trainings with them. We explain to them better. So for here, our during that process, that helps us a lot. For us, we engage different sets, as I earlier on said, we engage different sets of people in cohorts. Like for the children, for the 4 to 11, we engage more of the mothers, wherein we have to like meet this mothers club, you know, all this mothers group, the clinic, all. So for a certain cohort, we use different strategy to like reach the community people, the caregivers, and the parents. So far, that's what we did to help us gain the trust and within the community. Using being that some of us, like for me, I'm not from Cambia, but I've been working for Cambia community base before I was in the trial, and some of my colleagues we are from Cambia, so we are well known within the town. So that kind of we have already built that relationship before we entering into the trial. So they have a lot of trust in us. As Tom earlier on said, the trust level for the trial was through all these things, because most of the staff that we are recruited are locals and they are brothers and sisters. They will say, "Ah, no, my brother will not come and kill me." So something like that. So we usually like, this person, I'm working there, I'm your relative, you know I will not kill you. So if this vaccine is good, if this vaccine is not good, I will not ask you to take it because I'm here. If something happens to you, like I will not go anywhere, you will come to me and my household to deal with me. So something like that, give them a whole lot of try to build our relationship with them and their families. To the extent some of these participants have like what we call, where they have personal relationship with us. Sometimes they would even explain to you their personal and their private, what they are going through in their homes and all. So that's how we're able to like.
Thanks, Claudia. That's really insightful and useful. And I think I see Marie-Michelle and Bob nodding their heads, so it's familiar information for them as well. I'm just conscious that Tom has to leave us now at 4 o'clock, so my intention wasn't to give Tom the next word, but maybe I'll just ask him another question just so that we have the full wisdom of Tom before he leaves us. Tom, ethics is obviously a key issue in any clinical trial. And often then it gets a bit complex when you bring in community engagement and trust into that. Maybe you can say a few words around sort of that work and the ethics approach and the ethics within community engagement work.
Yeah, absolutely. And you're right. It's ethics is obviously incredibly important in clinical trials, and the way that marries up with community engagement is sometimes quite difficult if you've been working in an environment around sort of community engagement that is not related to clinical trials. So community engagement for a clinical trial is obviously subject to good clinical practice in the same way as the activities that take place within the clinic. So all of your community engagement staff are trained in GCP, and community engagement activities and strategies must follow those principles laid out in GCP, and that's obviously very important. I think in practical terms, there's a crucial difference between community engagement for a clinical trial and community engagement or social mobilization for the usual kind of health or social interventions that are promoted, particularly in Cambia where we were working. And that is that community engagement for a clinical trial is not about persuading or encouraging people to take part in the trial. So the vaccine in the trial is not a proven intervention. There are potential risks attached to taking it, perhaps, or to participating in the trial. So community engagement for clinical trial has to take a different approach. Community engagement is really the precursor to the clinical trial informed consent process. So information about the trial given during community engagement must be accurate, it must be consistent with the participant information form, it must correspond to the information in the protocol, and it's therefore about providing information to community members outside of the clinic setting that helps them to make a choice about whether to attend that first clinic visit and go through the informed consent process. And I think really that was our mantra, and sort of our ethics related mantra in Cambia in terms of this community engagement team and all of the training, that their job was to provide information to help people make a choice about participating. And a couple of things to mention. I said, ethics and community engagement can marry in a slightly difficult way. And I wanted to mention it's sort of not all plain sailing. And there's a couple of examples of where ethical requirements, I think, for a clinical trial could actually have the potential to create a barrier to trust building, at least in our experience, if they weren't well understood and carefully handled. So the first, and Angus mentioned the paramount chief participating and the importance of that as a trust building measure. But when we first set up the trial, there was certainly an expectation among many community members that all of the stakeholders and all of the trial staff should take part in the trial and receive the vaccine first. That would give people confidence. So those people should be made to go and take the vaccine before anything else. And of course, it was very helpful that the paramount chief voluntarily volunteered to take part in the trial, but it would be completely unethical to force anybody, staff or the leader or anybody else to participate in the trial. And there was, obviously we were unable to pressure community stakeholders to participate in the trial, which sometimes left us in a difficult position where some people seen as influencers had not wanted to take part in the trial for their own reasons, but community members were saying, oh, but I don't want to take part in the trial. I don't trust you people until my leaders are in the trial, or as you as staff, why are you not in the trial? And there are ethical guidelines around staff taking part in a clinical trial as well. So those kind of scenarios have to be handled carefully, respecting the rights of the individual to take part or not, while also appreciating that ultimately having stakeholders take part in a trial can be a very good confidence building measure. And I guess the second thing is participant and patient confidentiality. And during the course of the EBODAC trial, we unfortunately had several SAEs that weren't related to vaccination, but caused study pauses or were, well known that a participant had become ill. And in those situations, for obvious reasons, concerned fellow participants or community members want you to explain to them what is wrong with that participant if you're saying it's not related to the vaccine. But obviously for us as a trial team, it's not possible to reveal that without breaching the participant's confidentiality. And again, those are difficult situations to handle without then appearing to be breaching the trust of the fellow participants or the community by appearing dishonest. So, I think we tried to be very clear about the confidentiality requirements and that it was the right of people to give out their medical information if they chose to. But still, sometimes sometimes that does cause can cause an issue and has the potential to lead to questions around transparency, but is of course a really important ethical requirement for community engagement in the trial. And I guess to sum up, ethics in clinical trials are there to protect trial participants, and I think that very much applies to ethical community engagement as well. So it is crucial that ethical community engagement for clinical trials gives people accurate, honest, transparent, correct information. And to do that effectively in communities that are not familiar with clinical trials, you have to very carefully articulate the reasons behind sort of decision making that is related to ethics, like the scenarios that I've described earlier. And I think that comes back to sort of the principles we were talking about earlier, which makes that easier. If you have endeavored to be transparent, respectful, and to listen to feedback and sort of work together, I think that can go relatively smoothly.
And I think it also reflects what EBODAC and the different clinical trials it engages with as well, is this need for very tight communication among all participants supporting the clinical trial and making sure everyone is on board and clear with the same messaging, the same approach, and understands their various roles in it, because they can be often quite complex operating areas as well.
Yeah, I agree. And also, and those the different participating sort of organizations or sort of work streams or teams, but also and I mentioned earlier that the clinical team has a really important role to play in community engagement as well. And it's also true that that message and that approach to engagement and to dealing with participants and handling things like rumors needs to be right throughout a clinical trial team. It's not just the work of a community engagement team. It doesn't work if a participant then goes into the clinic and is told something completely different to what they're told in the community, or is treated in a different manner to how they're treated by community engagement staff.
Yeah. Thanks, Tom. I know at the start you mentioned social science, and Marie-Michelle has alluded to social science, and Angus has alluded to social science. So I think we should kind of look a bit more at that. And maybe Angus, you can start and tell us some of the social science work in Cambia and why it was so important. And then Marie-Michelle will come to you for your take of the social science work underway in Rwanda.
Yeah, thank you very much, Maurice. So just like what Tom was saying, we are trying to, because we realize that community engagement transcends beyond the community to down in the clinics where these participants go and interact with the clinicians themselves. So one thing we are doing was to first go in the community to understand what people's perceptions are about their general health seeking behaviors, not only about the vaccines, but about how they go to the clinics, when they fall ill, where they go. So we understood all those things. So part of our work was for us to try to strengthen the community engagement team in such a way that we feed back our findings to them so that those findings we give them could help them to shape the community engagement towards meeting the participants or the community needs. Because we realize that community engagement should not just be about making people to accept the trial, but for us to also listen to them and take on board their concerns. So that was what we are doing. So we basically supported the trial, the community engagement team in 3 ways. The first method we used was we did what we call the power mapping. In this power mapping exercise, we went to the communities. We tried to map who really have power, because we realized that power was not just meant for those with titles, but there are people in the community who really have no titles, but they have a lot of people that follow them. So we did that power mapping. We went to the community and engagement and showed them, if you really want to succeed in this community, let's engage this person, this person, and this person. And you know, within the communities, there are particular groups that maybe are not represented well. So we went down in the community, we map all these social groups, all those that have power, then we fed those back to the community engagement team for them to engage them and use them, or for them to help spread the message to their community people, because people really trust themselves better than whoever is coming to talk to them. The other activity we did was the rumor tracking, because the vaccine trial came in the community when we had the outbreak. And the outbreak, we all know that the outbreak had a lot of conspiracy theories, and there were a lot of rumors about how the outbreak itself was. People never believed that Ebola was a natural disease. They believed that it was man-made. So they had a lot of conspiracy theories about this particular outbreak. So when we went to the community, we realized that those rumors that were about the outbreak also spell over. They had a negative impact on the trial as well. So we are in the community tracking what people think about the trial, then feeding those rumors back to the community engagement team to help them to also to counteract those rumors, but whilst maintaining ethics. So one thing we did was we had to anonymize all our findings. If I'm telling you that if I take the vaccine, I will die, if we are reporting, we will say this person said in this community. But we'll never say this is what Angus said. We'll never show the names. We'll anonymize our findings, then feed those back to the community and engagement team, and also recommend to them what they should do for them to counteract those rumors in the community. Then the other thing we did was for us to really give them a rapid feedback. We built a rapid feedback mechanism in the sense that we had to organize weekly meetings with the community engagement team, so that we can give them our research findings within the week and recommendations on how they can act on those. However, we also had a rapid mechanism where we communicate to them immediately. In case we go in the community, we pick a rumor that is very, very dangerous, that could halt the trial. We'll communicate that rapidly to them, and they will go in the community and talk about that. Then, so these were the ways we are trying to support the community engagement teams, because we realize that people normally call social science as low science. That was a term I learned during our first EBODAC symposium in Senegal. So we'll try to make social science a very active science by passing our feedback rapidly so that people can act on them and see the essence of what we are doing. So this was how we are doing to support the community engagement team. Then for the clinics themselves, we realized that participants could go to the clinic, but they may have different perceptions, or they may have different experiences. So we track those live experiences using our exit interviews. So when participants go to the clinic, when after their last stage of the visit, we engage them, we interview them. We have what we call exit interviews, where we ask them to understand what their experiences were and what they actually like about their visit. So we fed those back to the clinical team so that they too could know how to talk to participants or what participants think about the visit, what they really like and things that they dislike. So in the nutshell, our involvement in the trial really helped in building trust, because we are only there to listen. Let me be clear here. In EBODAC, we had a clear distinction between the community engagement team and the social science team. The community engagement team, we are responsible to go in the community and speak or talk about the trial. We are only there to listen to what people have to say, though it is very difficult, but we train our staff to at least do that, and we really succeeded in that, because since we are there, we maintained that trust, and that led to the success of the trial. Because nobody ever told us that you came yesterday, I told you this, and now people came here and asked me about that. Because we really anonymize all our findings and make sure that people really adhere to our ethics as well. So that was how we supported the trial and the community engagement team.
Thanks very much, Angus. Marie Michelle, I saw your head nodding there. You've been a strong advocate for the use of social science in our Rwanda response as well. Can you tell us why it's so important and some of the aspects from Rwanda?
Social sciences is very important, I think, whenever you have the activity, whether clinical trials, whether community engagement, because social sciences is a very strong tool to help those activities to be done efficiently. So when we started the Umulinzi program, social sciences was not planned. But as a social scientist, I could see that we are missing a very important part. So I started trying to approach people, London School, EBODAC, World Vision, to assist us, because the work we are doing with the Ebola vaccine, it's a huge work, it's a huge responsibility, and it's a huge information that would be missing. So when we got support, we started doing social sciences, and we got very, I would say, by the time we started social sciences, it was a very very good timing, because it was in the middle of work where it gave us even a chance to know who to target, who should be involved in the community, in the focus group discussions, individuals, and also it also gave us a chance to know which kind of questions we would ask, because by the time we started, we had already faced challenges like rumors in the community. People would not even come for second dose for various reasons. So for questions, for developing questions, it was really easier for us. So the findings, even though we are not ready to provide the findings, but already we are using the findings from these qualitative data collections to improve our work daily, our mobilizations, because community were open enough even to tell us what we should change in our daily activities, and their concerns. So we tried to put in practice what they have been suggesting. In those groups, we invited the people who have been vaccinated for first dose and second dose, people who completed second dose. We interviewed local leaders, community health workers, family in general. So those all data, I believe it will be a very good report due to what we have found.
Thanks very much,
So
Marie
we
Michelle.
are even our. So go ahead.
No, I was saying what's evident from both what you and Angus are saying is the importance of the social science work to improving the program, but also for it to be agile and responsive, and as you're using it to amend your program as you go along. So it's not just a piece of research for the sake of a piece of research. It is really research that is helping us improve the delivery of our program and helping us continuously improve how we deliver on our programs, which I think is a really important point. So we're not just doing research because it's nice to do the research, it's also really improving the quality of our programs.
Yes.
Which is it's an important point.
Yeah, that's it.
Thanks very much. I'm just conscious that we're running out of time and we'll be in trouble with everyone for keeping you all too long, but it's a very interesting discussion. I just wanted to go back to Bob. And Bob, you mentioned about the fact that COVID-19 is causing some disruptions and some complications to the vaccine program in Goma. And maybe you could tell us more about both the challenges of the community engagement work in the context of COVID-19 and how you're overcoming those. So both how you're engaging with community members and some of the sort of challenges that's bringing up in trust for the community.
Thank you very much, Maurice. I think it was very important for us to communicate effectively on preventive measures against COVID-19 in order to avoid this pandemic having an impact on vaccination and avoid misunderstanding around Ebola and COVID-19. We continued with the same strategies. Door-to-door communication, community feedback collection, advocacy with religious and local leaders. But we are facing some challenges because a part of the community would like to see COVID-19 patient or people who are diseased to believe that the pandemic exists, because they have seen many deaths in some countries like Italy or France or United Kingdom. Maybe they expected to see the same things in DRC, especially in Goma. So it's not easy to explain them that it's not allowed to show you people who are sick or people who are diseased. And but some people are still able to accept and adhere to barrier measures, but the state of poverty in community is also a challenge to the acceptance, because in some places we are raising awareness. Water, which is an important element to fight COVID-19, there is no water for them to use for washing hands, for example, and getting a mask is still difficult for some households. So for this reason, we communicate on the responsibility of community, so that it also acts for its own health without waiting every time from government support. So we have developed a network of influential religious leaders in our area of intervention, and that members help us to raising awareness community, to support them to act for themselves, if I can say. Thank you very much.
Thanks very much, Bob. That's very good. Claudia, I'm going to give the last question to you, so you'll have the last word. I'd be interested to hear how is community engagement and taking on board the ethics point that Tom made earlier, that our intention is never to force somebody to be a participant of the trial. But how did we go about engaging members of the community who may not have always hear about the trial? So women, people who are marginalized, sometimes the disabled. What community engagement strategies can we use to to make sure that everyone in the community is being reached by these messages and understands that they are allowed to participate in the clinical trials?
As I earlier on said, we targeted different set of people, and we do that through different strategy, different activities. Like we use radio discussion. We had a discussion. We know some of the community people listen to their local radios. So we do radio discussion and jingle. We did that activities. And as well, we noticed that some people are not able to like listen to their radios. So what we did, we normally visit their homes, even though it was difficult for us to reach them, because for Cambia in the afternoon, if you go there to their houses, you will not find anyone. So like we have to strategize our sensitization, like we go there early in the morning and late in the afternoon. So we reach those people that we think they are unable to reach through the radios and through our meetings. So we engage them one-on-one. We went to their houses like late in the afternoon, we sensitized them, talked to them. We went to the handicap homes, we sensitize them, we meet with their heads, we talk to them like we first of all go and book a date that we want to, at this date we want to come and visit your people. So if we met the chief or whosoever we met, the elder in that particular area or community, they will like suggest a date. So we don't want you to come at this time. We come at this time to find everyone. So normally what we did, we work alongside with the community people or the stakeholder or the influential person in that particular community. So we work alongside with him or her so that he can give us an appropriate time to meet these people so that we can engage them, sensitize them on our sensitization messaging. All we have to do is to give them our message. If they accept or they were willing to take part in the trial, then we will take their names down and take it to the clinic. So basically, that's what we normally did. As I said, we went to the schools, we went for meetings, we went for radio discussion, drama, we conduct street drama, wherein we get our sensitization messaging in different languages, and then we explain to them during the drama session. We wear our jackets that states EBODAC or EBODAC. Wherein someone we as well told them, if you have any question, you can find those people that are wearing the jacket. You ask them your questions so that your question can be clarified. Questions that we are unable to ask, which is clinical question, we will tell them, okay, give me your phone numbers. When we go to the clinic, we have this, your answer, we can call you and give you feedback based on the question you ask. Questions that we can answer, we answered them there. So basically, that's what we are doing.
Thanks very much, Claudia. And I think what it draws and what's a continuing theme is understanding the community. So it's the value of ensuring that community engagement is led by people from the community, who know the community and know their community members. And that's what's made it effective across the board, I think. So and then something that's really come across for me as well is traditional leaders, and that sort of knowing and working and having good relationships with whoever are the leaders within a community, be they traditional, be they the church, whoever those key trusted allies are within the community, are essential for ensuring that that strategy works. I'm sorry, we've run out of time. I know everyone here has lots more to say. And hopefully we'll have another day where we can have discussions, and sometime maybe we'll all get to meet again in person and have these discussions together, which would be very useful. I'd like to thank you all for your great contributions today and for your sharing your knowledge and skills with everyone who's interested in this. It's been very appreciative. I've been reminded to tell everyone who's interested to ask any questions or follow up of any of the panelists that they should submit their questions via the Pigeonhole, which they will have found on the portal that they received to come to our session here today. And we look forward to seeing many of you on the live session on the 21st, which is tomorrow. So thank you all for your work and for all your insights today, and we much appreciate it.